talk is based on a non-infectious keratitis. We know that's a large gamut of disorder affecting the cornea. And we have a person who's had a lot of experience in this, Dr. SONAL TULI. She's from Florida, and she's going to talk about this entire gamut in a very precise and manner which we all would understand.
Thank you, sir. I appreciate it, and I appreciate Rajesh and Namrata giving me the opportunity to present here today. It's really great to be back in person. I haven't been to India for 3 years, so it's really nice to be able to come back and see everybody, old friends, I guess not old friends, but long-term friends in person. So I'm going to be talking about non-infectious keratitis, or as I like to call it, what's wrong with this picture. You've seen some excellent presentations today about all kinds of infectious keratitis, and you see a lot of those. In Florida, we do see a lot of infectious keratitis, but about 50% of the patients that I see with ulcers are non-infectious. And so really what I want you to think about is, when should you start thinking that this is a non-infectious ulcer? I have no disclosures, but this is, as you know, an infectious keratitis. This is a typical Pseudomonas or gram-negative infection. You see a lot of purulent discharge, a very ill-defined ulcer, there's a hypopyon, and you might start seeing a ring because there's an antigen in the center and antibodies coming in from the periphery. So we're going to look at some other ulcers, and you're going to think about what is different about these. So looking at this ulcer, you can see that you've got the infiltrate in the center, but a lot of whitening around it. A very well-defined ulcer, and even though you think that this might be an infectious keratitis, the discharge is not purulent, it's tearing. They're tearing from the eye, they've got a lot of pain. And given this whitening and the amount of pain that they have with this, you're thinking it's not neurotrophic, right, because they have pain. They are tearing, but they're not producing any discharge. And so ask them to close their eyes and look for exposure keratitis. So especially if you see an inferior ulcer that has minimal discharge, you see a lot of whitening around the ulcer, and that tells you that this is a chronic problem, not an acute problem, because that would have ill-defined purulent margins. And then they will have discomfort, which distinguishes this from a neurotrophic ulcer. How do you manage that? Just like you would any other ulcer, non-infectious ulcer. You lubricate it, you keep the eye closed. Tarsorrhaphy, moisture goggles. Sometimes you can even put a bandage contact lens so that this area doesn't get exposed. And a lot of the patients that we see with these are in the burn unit, where they can't close their eyes, but you also don't have anywhere to stick a mask or put goggles on, and you can use the clear wrap that you use for food on their eyes to protect it after you put ointment on the eye. So here's another inferior ulcer. This one is very well defined, not a lot of infiltration. Again, no purulent discharge, which makes you start thinking not infectious. But also it's a very dry eye. It's not a very teary eye. These patients will come in complaining of blurred vision rather than my eye feels like there's a rock in it. And so the moment a patient comes in and you see an ulcer on their eye, but they're not complaining of pain, you immediately start thinking of a neurotropic component. In this case, if you look carefully, my pointer won't work. If you look carefully, you can see in the center, there are some keratic precipitates, which gives away that this is probably secondary to HSV or VZV. And similar looking ulcer here, well-defined margins, thickened borders, and we'll look at that in a moment, why those borders thickened. But it's usually, why do you get these ulcers? Because patients don't have any sensation in their eye. They're rubbing their eye, they don't realize it. When something flies into their eye, they don't produce tears to wash it out of their eye. They don't have growth factors that are coming in from the tear film, so they cannot heal epithelial defects, and that causes a neurotrophic ulcer. Often it's very hard to distinguish, especially with somebody who's got a history of HSV. How do you tell HSV from a neurotrophic component? Because the treatment will be very different. If it's a neurotrophic ulcer after HSV, you probably want to put them on some steroids and not use topical antivirals because those are toxic. So looking at what happens with HSV, you all know that the staining pattern, rose Bengal stains the dead cells around the edges, and fluorescein stains the epithelial defect in the center. In a neurotrophic ulcer, you have an irritated, inflamed base, so epithelial cells are being produced by your limbal stem cells. They come up to the edge of the ulcer, but they cannot heal across the ulcer, which is why you get these really thick gray edges. And then you have dead, dying cells in the center that cannot survive because of all the inflammation. So those stain with rose bengal, and then when you put fluorescein, they leak through that and cause a nice green glow around it. So what we call as reverse staining. And here you can see examples of it. Up here is an HSV ulcer, green in the middle, red on the outside. And here's a neurotrophic ulcer with a red on the inside and then this green glow on the outside. So that can help you tell that even though it looks like a dendrite or a geographic ulcer, this is not live HSV. This is a neurotrophic component. I want to put these patients on oral antivirals and steroids probably to help it heal. How do you heal any other neurotrophic ulcer? You want to lubricate, just to put lubrication in there to diffuse the growth factors that they might have. Bandage contact lenses, hypertonic saline, and then of course things like autologous serum, which will give you serum-based growth factors in the eye, so that will help it heal. There's epithelial growth factor, there's IGF, and then of course in the US, I don't know if it's available in India, but we have the recombinant nerve growth factor drops that can be used to help the epithelium heal. Very, very expensive, very hard to use, but they are effective. We do use amniotic membranes for these, and the reason for that is that the basement membrane, which is the top surface, has collagen and laminins and fibronectin that help epithelium grow. And then the base, the stroma, has growth factors, it has anti-VEGF, so it prevents inflammation. So the combination of the two helps epithelium heal. We've done a few of these neurotizations. I don't know if that's done here regularly, but what you do is you take a nerve from the leg, and you connect the supratrochlear nerve from one eye, the normal feeling eye, to the opposite side, and then you break up that nerve into its little pedicles, like a little octopus, and you put it around the eye that has the neurotropic component to it, and these nerves then grow into the eye and neurotize it so that they can get sensation back. It doesn't always work, but when it works very well. They initially feel the sensation on the opposite side, but then their brain learns to feel it on the right eye. So what's wrong with this picture? It looks like a neurotrophic ulcer, but this one is superior. You don't typically get neurotrophic ulcers superiorly because it's protected. The other thing you're looking at is this grayish material in the center. And so this tells you that something is going on in the upper lid. You see a lot of this, way more than we do. And then you can see here the epithelial defect and a lot of toxicity around that. Flip the lid and you see that this is a patient with VKC, and what they have is a shield ulcer. It starts out looking like farinaceous, which is sort of like atta thrown on the cornea, and then it combines into this ulcer with this material, dead material in the center. To treat it, besides the treatment for VKC, you really have to debride this material off of the ulcer and then put a bandage contact lens to put a barrier between the eyelid and the cornea. What's wrong with this picture? You have a ring ulcer. Why do you get rings? Because there's an antigen in the center, like a fungal ulcer, antibody coming in from the periphery, from the limbal stem cells, from the limbal vessels, and they meet in the center to form a ring. But here there's no antibody in the center, there's no infiltrate. So this is both eyes of one patient, and you can see from this eye that there's very dry, lots of epithelium missing. This is actually alkane toxicity, so topical anesthetic toxicity. So if you see ring ulcers in both eyes, especially if they have a lot of pain, but when you test their sensation, it is decreased, that should make you start thinking of anesthetic toxicity. I won't talk about flectenules. You see a lot more of those than I do. I'll talk about one more thing. What is wrong with this picture? Typically, you get ulcers in the center of the cornea because that is avascular and it cannot fight infections. Here you have an ulcer in the periphery. You shouldn't get ulcers in the periphery because your limbal stem vessels should protect you. If you get an ulcer, especially this overhanging ulcer, that should tell you that the ulcer is coming because you have inflammation coming from the periphery, from the limbal stem cells, of the limbal vessels, I keep saying stem cells, and that tells you that this is probably PUK or murines. So these are the inflammatory mediators are going through the bloodstream and they get ejected out at the limbus and they cause a melt in the peripheral cornea. This is really important to diagnose because you can actually save this patient's life. The mortality with PUK is about 50%. over 10 years. If you put them on immunomodulators, their risk goes down to 0% if you put them on the right treatment. You start steroids, you might want to cut the conjunctiva and throw it away so that there's less blood vessels near the limbus to prevent the inflammation from getting to the limbus. And then you can use glue and you can use little baby PKPs to help cause a barrier. We won't talk about tetracyclines, but I do use these in all ulcers along with vitamin C. Low risk, but it may benefit because it prevents the matrix metalloproteinases from melting the cornea. And then steroids we've talked about earlier already. But use it if there's inflammation, don't use it if there isn't. So again, too many symptoms, too little symptoms, location, the way the epithelial defect appears. If you have bilateral ulcers, start thinking of this. If they keep coming back, think it's non-infectious and look for associated problems. Thank you.
Thank you very much, Dr. Tuli. It was a wonderful presentations and the documentation of cases so clear, and it was absolutely delightful to see those pictures, and the explanations given to the audience was wonderful. In the meantime, Dr. Rajesh Fogla will prepare his presentations. Any question at this time for Dr. Tuli? Okay. Dr. Tuli, do you have any sort of differentiation of these non-infectious keratitis in your part of and in Indian scenario, like in terms of patient profile wise? In your place also, you'll have a differential racial inclination, like white and this thing.
Right, so we definitely see the vernals and the shield ulcers in the African American population, not as much in the Caucasian, whereas we tend to see more of the HSV related neurotrophic components in the more Caucasian population. They've also more squamous cell carcinomas that have been removed and cut the trigeminal nerve, which can cause neurotrophic ulcers. So we definitely see and then of course, if I see a flictennial, it's almost always from somebody in India because of the TB risk, so.
Thank you, Dr. Tuli. Dr. Jain.
I have one question for you. What stage you would like to do neurotization? We have done around 13 cases using dural nerve, and most of the cases are either herpes or herpes simplex following neuroparalysis. Do you, it works only in around 50% of the cases in our hand. We have a follow-up of around 9 months now. So in your hand, does the corneal haze or some opacity, they do disappear after a long-term follow-up?
So we've definitely, so again, our success rate is about 50% as far as getting the sensation back. We do put them on the growth factor also at the same time, thinking that maybe that would help the nerves grow back. And so we don't know whether it's the neurotization or the Cenergimin that helps with the rehealing. But certainly once their cornea becomes more moist, that haze does tend to get better. Even if it doesn't get better, their vision improves. So they're very happy with that. Thank you for that question. Yes, ma'am.
Explain the role of ATT.
The role of ATT.
Antitubercular treatment.
Oh, absolutely, for flictennular keratoconjunctivitis. Interestingly enough, in the US, if I see it in an American person who has never traveled overseas, it's usually because of blepharitis, posterior blepharitis, so rosacea. So we'll treat them with rosacea treatment, and we don't usually test them for tuberculosis. The people that we test for tuberculosis are the ones who've traveled overseas or are from a different country, usually from India or Africa. And then in those cases, I do put them on anti-tuberculous treatment, and they tend, obviously we put them on steroids topically for the treatment of the acute episode, but then to prevent future episodes, we do put them on anti-tuberculous treatment. If they have flictennular keratoconjunctivitis, that's almost a reason to put them on anti-tuberculous treatment if they test positive.
Yeah,
Great question.